Hello, my name is Kristen Watson, and in this presentation, we are going to be talking about drug-induced hypertension. As we know, most cases of hypertension or elevated blood pressure are due to essential hypertension. However, secondary causes of hypertension occur in up to 5 to 10% of patients with hypertension. The most commonly recognized causes of secondary hypertension include things such as chronic kidney disease and obstructive sleep apnea. However, drug-induced hypertension can play a role in select cases. And while these secondary causes of hypertension lead to a small proportion of the cases of hypertension, drug-induced causes should be evaluated for in all patients with hypertension. As we are going to talk about in this presentation, while drug-induced hypertension may occur, in many of the situations, it may not be appropriate to remove the offending agent, and we're going to have to treat the hypertension accordingly. So it's important to identify when there is the case that we use the correct treatment options to treat a specific cause of drug-induced hypertension. There are numerous medications, illicit substances, and herbal products that have been associated with elevations in blood pressure and causing cases of hypertension or worsening of hypertension in patients who already have the diagnosis. This is not a complete comprehensive list of medications and substances that can cause elevations in blood pressure, but it gives you a sampling of many of the ones that most commonly are associated with this. In these next few slides, we are going to talk about different agents, the mechanism by which they cause drug-induced hypertension, the incidence of this, and as well as how do we manage these patients. Drug-induced causes of hypertension occur for a smattering of different reasons. It includes things such as fluid retention, things as activation of the renin-angiotensin system, direct vasoconstriction due to stimulation of alpha receptors, such as in the case of cocaine. And in some cases, it's not well understood why drug-induced hypertension occurs with specific agents. The first class of medications that we are going to talk about is oral contraceptive therapy. And this is really dealing with the estrogen component. Patients who receive estrogen for other causes can also develop hypertension, but we're going to focus specifically on those receiving oral contraceptive therapy. In looking at patients who were current users of oral contraceptive therapy compared to the women who have never used this regimen, the relative risk of developing hypertension is 1.8. The risk in women who have used oral contraceptive therapy, but then discontinued use, they still have a 20% increased risk compared to women who never use. So current use of oral contraceptive increases your risk of elevation in blood pressure, but prior use can also contribute compared to patients who did not ever receive therapy. The mechanism by which oral contraceptive therapy increases blood pressure is multifactorial. That may lead to volume retention. Therapy may also stimulate the renin-angiotensin-aldosterone system. The risk factors for developing hypertension associated with oral contraceptive therapy are women who developed hypertension during pregnancy. There's a family history of hypertension. Other risk factors include cigarette use, obesity, comorbid conditions such as diabetes and renal disease. The higher the formulation or concentration of estrogen a woman is receiving, increases that risk of, is associated with potentially higher risk of developing hypertension. So when we're prescribing estrogen therapy to patients, we want to use the lowest dose of estrogen that is possible to minimize this risk of hypertension developing. In patients who are receiving estrogen therapy, either oral contraceptive therapy or not, blood pressure should be assessed at baseline and then every 6 months thereafter if the patient does not have elevations in blood pressure. If elevations occur, we want to make sure that we're monitoring the patient more closely and that if needed to make adjustments in therapy for that. If hypertension does develop or blood pressure control gets worse in somebody who is on estrogen replacement therapy, we need to assess if we're looking at contraceptive therapy, taking the patient off of formulation that includes estrogen or decreasing the amount of estrogen the patient's receiving. We can look to use other contraceptive therapies, such as our progesterone-only therapies and our non-hormonal therapies for women. That decision on what to change to needs to be made in conjunction with the patients, as there are numerous different types of contraceptive therapies. We need to see what will work best for a given patient scenario. If the patient needs to continue on that therapy, we want to make sure that we treat the blood pressure accordingly. Once that blood pressure becomes elevated, most likely it is going to stay elevated unless treatment is discontinued. In a patient who has elevations in blood pressure and may require treatment of that blood pressure while on therapy, we want to make sure that we assess the blood pressure about at least 3 months later in patients to see what is occurring, because with withdrawal therapy, blood pressure will in most circumstances are going to decrease if it was due to contraceptive therapy, and thus adjustments in antihypertensive therapy may be necessary. The next thing we're going to talk about is the use of erythropoietin agents. So hypertension develops or worsens in 20 to 30% of patients who are receiving therapy. I would imagine, based on how we're using erythropoietin therapy and the aggressiveness in which we target hemoglobin goals and the levels that we're trying to get to, that this number may be a little bit lower in current practice, but the potential exists in up to 20 to 30% of patients. There's multiple reasons or mechanisms proposed in which erythropoietin leads to elevations in blood pressure. This may be due to increases in endothelin-1, which is a potent vasoconstrictor, activation of the renin-angiotensin system, and or arterial vasoconstriction, among other potential methods. The rise in blood pressure can occur as early as 2 weeks in therapy and can be seen even after 4 months of therapy after it has been initiated. Most commonly, these rises in blood pressure occur in patients who their hemoglobin has increased quickly or to high concentrations. Over the past decade, things have changed in practice in where we are not targeting as high as hemoglobin concentrations in patients who receive erythropoietin therapy, because that higher concentration of hemoglobin, higher target, is associated with worse outcomes than what our current standards of practice are. We also want to make sure that we are following prescribing guidelines in initiating therapies at the appropriate dose so that there's a gradual rise in hemoglobin concentrations versus giving a large dose up front. Risk factors for developing therapy, as I talked about already, include quick rises in hemoglobin. Patients who are on hemodialysis versus those who are getting continuous dialysis are going to be at higher risk for developing therapy. So continuous being our peritoneal dialysis patients. Patients with a family history of hypertension. There's also a dose-dependent response with the likelihood of developing increases in blood pressure. How do we manage this? The subcutaneous form is associated with less abrupt rises in blood pressure. So the subcutaneous form is used when possible. Again, we're going to titrate our therapy slowly so we don't see the abrupt rises in hemoglobin concentration. If hypertension does develop, a patient who is on erythropoietin, there's no alternative typically for these patients unless they would not need therapy anymore. So we're going to have to treat through it. So we're going to treat with the appropriate antihypertensive therapy for patients. And we're going to look at what would be appropriate therapy based for this patient on compelling indications, such as their chronic kidney disease or other indications that may be present. If needed, you can look to reduce the dose of erythropoietin therapy, but again, you have to weigh that with the risk of benefits of achieving your hemoglobin goal for patients. The next class we're going to talk about is the nonsteroidal anti-inflammatory drugs, or the NSAIDs. The incidence of its causing hypertension or elevation in blood pressure is not well established. It has been reported that patients can have up to a 5 millimeter mercury increase in blood pressure. we know that increases of blood pressure, even by 2 to 3 millimeters of mercury, can be significant and lead to worsening outcomes. So 5 millimeters of mercury, while it may not seem numerically like a lot, it can have implications on outcomes for patients. There is conflicting data on which NSAID or the selective versus non-selective, is it our COX-2 inhibitors, are they more associated with substantial elevations in blood pressure? It's not, the data is kind of all over the place. So we want to think about it as a class effect. Those at highest risk for developing increases in blood pressure include our elderly patients. So when this does occur in patients, we want to look for alternative therapies for patients. Again, anytime we're looking to recommend nonsteroidal anti-inflammatory drugs, we always want to look at the patient's overall risk of cardiovascular disease and adverse events with nonsteroidal anti-inflammatory drugs. We also want to look at other potential risks, such as the bleeding risk in the patient. When necessary, we would want to discontinue therapy or recommend an alternate therapy for these patients. Cyclosporin and also other immunosuppressants such as tacrolimus are associated with elevations in blood pressure. Patients who receive cyclosporin for non-transplant indications, up to 50% of patients have been reported to see elevations, so worsening of hypertension and or the development of hypertension in patients. When looking at the use of cyclosporin for indications such as transplantation, that up to 80% of patients have seen elevations in blood pressure with therapy. As I mentioned, tacrolimus can also cause elevations in blood pressure. The reported rate of this is less than what is seen with cyclosporin therapy. The mechanism is not well substantiated, but it's believed that these therapies cause systemic vasoconstriction. So in many patients who are receiving immunosuppressant therapy and develop hypertension, we are not going to be able to take the immunosuppressant therapy off for these patients. So we're going to need to treat the hypertension accordingly in these patients. When possible, we will lower the dose of immunosuppressant therapy, but we have to take into consideration what are the levels that we need to achieve to prevent organ rejection in patients. So the answer is, in many situations, is going to be to treat the hypertension accordingly. In patients who receive cyclosporin and develop hypertension with therapy, these patients, the preferred treatment option for these patients is a calcium channel blocker. The use of diltiazem and verapamil is commonly used as we take advantage of the drug interaction with that. So the administration of diltiazem and verapamil are going to increase cyclosporin concentrations, so the patients will then need to have a lower dose of cyclosporin. So if diltiazem or verapamil are initiated in patients with cyclosporin, monitoring is going to need to be taken so that appropriate dose adjustments in cyclosporin can be taken, because higher dose concentrations are associated with numerous side effects for patients. One of the last groups of medications we're going to talk about is the use of glucocorticoids. It's estimated that hypertension develops in up to 15 to 20% of patients. The risk increases with escalating doses, the duration of therapy, and with patient age. The mechanism is believed to be due to increased sensitivity to catecholamines and or increases in sodium in blood volume. The patients have been reported to have up to 15 millimeter of mercury increases in their blood pressure with treatment with glucocorticoids. Diuretics are often recommended as the first-line therapy in patients who develop hypertension due to this, and this is because the theory is that the mechanism is due to increased sodium and water retention. In many circumstances, chronic glucocorticoids, there may not be an alternative option for the patient, so we will have to treat through it. At any time in a patient who is receiving steroid therapy, we always want to make sure that the patient is receiving the lowest possible dose. So if blood pressure elevations do occur, we want to assess if the dose is appropriate for the patient. In patients who have tapering of steroids over time, we do want to keep an eye on what their blood pressure does with dose adjustments of steroids, because we may need to adjust antihypertensive therapy accordingly. Now, when we think, and this is, we're talking more so with chronic therapy, we may see some elevations in blood pressures with short courses of therapy. In those patients, unless like a hypertensive crisis occurred, we would just want to monitor the patients and ensure that their blood pressure does resolve with discontinuation of therapy. The effects on blood pressure from steroids is typically reversible. The last class of medications that we want to talk about are vascular endothelial growth factor inhibitors, so agents that are used for different oncology-related conditions, including agents such as bevacizumab. So these agents are becoming more and more frequently used. Elevations in blood pressure has been reported in up to 32% of patients receiving therapy, and this seems to be a class effect. The frequency of hypertension or elevation in blood pressure that has occurred in patients varies slightly between medication to medication, but we want to think of it as a class effect and something we would monitor for in all patients who are receiving therapy. While the patients may have worsening of hypertension or new onset hypertension with therapy, with more seeing worsening of hypertension than new onset, hypertensive crisis has been reported. So we want to make sure our patients are aware of the signs and symptoms of what a hypertensive crisis is and ensuring that we're appropriately monitoring our patients. The mechanism by which this occurs is maybe due to a decrease in nitric oxide production with administration of therapy, as well as activation of the endothelin-1 system. In patients who receive one of these VEGF inhibitors, the risk factors for this is who develop hypertension or worsening of blood pressure are those who are older, patients who receive one of these agents for renal cell carcinoma and have pre-existing hypertension. The risk for worsening blood pressure or increases in blood pressure also appears to be dose-related. There is some data to suggest that in patients who have rises in blood pressure that that actually may be indicative of a response to treatment. So while we don't want elevations in blood pressures to occur, it's just something to keep in the back of our mind. I would not, though, say to a patient, well, your blood pressure increased, so that means that your therapy for your malignancy is getting better. That is not data that has been well substantiated. The blood pressure changes with administration is often transient and can be reversible. So when patients are on this, we want to make sure we're frequently monitoring their blood pressure, adding or adjusting antihypertensive therapy as well. It is recommended in patients who develop or have worsening hypertensive control with this therapy is that treatment is with one of the RAS inhibitors, such as an ACE inhibitor or an angiotensin II receptor blocker therapy, diuretics, or amlodipine. It is recommended that the non-dihydropyridines, being verapamil and diltiazem, or nifedipine, not be used, and that is because those agents have been associated with increases in vascular endothelial growth factor. So the thought is that you could, by giving them for treatment of hypertension, there could be more VEGF there, and then perpetuating the increase in blood pressure. So treatment of hypertension in these patients is our first line options that we'd be doing for patients: an ACE inhibitor or an ARB, a diuretic, or a calcium channel blocker such as amlodipine. This, I feel, is a really great review article that goes into this information about treatment of hypertension, goes through the mechanism with the various agents that have been shown. So it's a great review if you want to learn more information on this. Product labeling can also be very helpful in the expected rise in blood pressure that can occur with a specific agent as well, and if it is reversible or not. In summary, in patients who are receiving medications that are known to cause drug-induced hypertension, those patients are going to need more frequent monitoring of their blood pressure, especially those who have established hypertension. We want to keep in mind that even though an agent may worsen blood pressure control, if it is clinically indicated, such as in the circumstance of immunosuppressant therapy or a VEGF inhibitor, it would not be a reason not, if the blood pressure is controlled, it would not be a reason to withhold therapy. We just have to be more frequent with monitoring. If you notice on the early slide, a lot of our psychiatric medications also can cause worsening blood pressure. But if that medication is what is needed, we just need to monitor and treat our patients accordingly. But in many cases, such as in the case of nonsteroidal anti-inflammatory drugs, we may have an alternative that can be used for the patient if hypertension is worsened. If the hypertension develops, we want to treat accordingly. And if the offending agent is withdrawn, we want to make sure that we monitor the blood pressure closely after discontinuation if the patient is receiving treatment for their hypertension, as the blood pressure control may improve and any titrations that we made during the course of the therapy with the offending agent may need to be decreased. Thank you.